So this is the second video in the vital signs series, and we're specifically going to look in this video on when we assess vital signs. And what we'll see is there's two main types that we're going to assess vital signs. In the pre-participation physical exam, and then in emergency situations. And you can see the differences as far as purpose, when that would occur, and how it occurs, with the purpose being similar in identifying underlying health conditions, but one's more with internal conditions in an emergency, and other are risk factors associated with sudden death during participation. As far as the pre-participation physical exam, we'll spend more time on that when we talk about sudden death in athletics during the second unit in this course. So we're going to spend the rest of this time talking about emergency evaluation and the use of vital signs within the emergency situation. And you can see the overall algorithm and flow chart associated with this, with a situation where if we have a non-life-threatening situation, we're going to end up going into our secondary assessment. And so we divide this into primary and secondary assessment in emergencies. And then initial assessment or primary assessment is designed to be completed within the first 15 seconds of arrival on the scene. We're going to focus on the overview of the injury, the mental status on the AVPU chart for different levels of consciousness. Anything below alert is considered unconscious in a medical emergency, and then assess the ABCs. And this is all the CPR, first aid sort of stuff that you talked about. So we're going to focus first off on the idea of stable and unstable athletes and high priority conditions associated with that. So if we have a stable athlete, that's when we move into checking to try to identify what condition they may have, and if they have any of these high priority conditions that we missed and could possibly become unstable. So unstable and high priority conditions are all going to be immediately transported. So we might collect vital signs in the meantime, but we're not going to be waiting around for the vital signs. We're only going to collect vital signs if somebody is stable and their primary assessment does not indicate any of those high value or high critical conditions. And so the secondary assessment then is once we begin, we try to determine the extent and specific type of the injury. And there are two different types of secondary assessment, a trauma-based assessment and then medical conditions. And so you can see now, based off of this, we have an unconscious medical condition. Right? We're going to primarily go straight through this to get them referred, because really with this loss of consciousness, if they're unconscious, we're really going to stay primarily in this primary assessment. But you can see we would be collecting vital signs second after our rapid head-to-toe physical exam while we're waiting for transportation. In a conscious individual, we'll see vital signs again go second after our history and then before our physical exam based on their chief complaint. Trauma, again, with the significant mechanism of injury, see vital signs second after the physical exam. You see this very similar as far as the how specific it is. If we have a non-significant mechanism of injury, we're going to primarily go into our physical exam. So think of this then as the similar aspect to your on-the-field evaluation. You would then come off the field and collect their history and then their vital signs. And so let's look at these different components within the secondary survey. First is history taking. And they look then at the sample history. So sample is an acronym standing for Signs and symptoms, describe, so you'd ask them to describe what their chief complaint is, what's wrong, where it's going on. You ask about allergies to medications or any contact allergies. Obviously, this is information that would be needed for advanced treatment. Medications, what medications are they currently taking? Again, looking for any possible interactions with medications we might need to administer in the emergency situation. Their past medical history, right? Have they experienced this in the past? Who is their regular physician that we might go through? Their last oral intake, when was the last time they had anything to eat or drink, and what was it? This is important for the possibility of emergency surgeries with that, or whether or not it's worth delay because the risk associated with surgery after eating. And then events, has this ever happened before? Within that history, then, we have a specific acronym for the pain assessment, and that is OPQRST, pain, right? What is the onset of the pain? What happened? When did the symptoms start? What provocation is for P? What actions increase or decrease the symptoms? We then will ask the patients to describe the quality of their pain, meaning describe their symptoms associated with that. Ask them to use different adjectives to describe their pain with different types of pain, indicating a variety of different conditions. And one of those specific ones is radiating pain that is associated with nerve injury. But we can also use this R for what region is the pain and what relief might there be. And so we're asking here also for what symptoms outside their chief complaint they may be occurring. We also ask severity of pain, and scale of 0 to 10, that's part of that pain being important within that vital signs as well. And then the time, when did the symptoms begin and how have the symptoms changed over time, specifically with regard to pain. The physical examination then that is included there focuses on looking for deformities, contusions, abrasions, punctures, burns, tenderness, laceration, and swelling, right? Because in this physical examination here, we're mostly concerned with any potential life-threatening injuries or injuries that are going to be made significantly worse in moving the individual. We're not really trying to form a diagnosis during the secondary assessment. That would come more later. And then we saw the vital signs, right? Pulse rate, respiration rate, blood pressure, and skin temperature being the 4 main vital signs. But also in there, depending on the importance, we may include pain, capillary refill, and pupillary reaction are also important. And pain, goes back and forth between whether it's a history or a vital sign, but it's always included. And then you can think of capillary refill and pupillary reaction might only be needed in certain situations. So when we assess vital signs, which is what we're focusing on, right, it's first and foremost important to understand the normative values and the fact that these normative values are very dependent on individual characteristics. And you can see a whole checklist of different things and different changes associated with vital signs in table 9.1. So take a look at this and see some of the differences that are affected and changed with vital signs. And this is why we will look at what we call baseline vital signs. And the baseline vital signs are the first vital signs that are assessed during the secondary assessment. And this will establish those normative value for the athlete's current condition. We can compare those to normal values as well as any documentation we have of previous things. But what we can do then with that is monitor change. And so we want to assess these baseline vital signs as quickly as possible and document those findings so that way we can get to the ongoing assessment of the vital signs, which are just as important, if not more important. In an unstable athlete that we're referring already every 5 minutes, in a stable athlete, it says every 10 to 15 minutes. and we compare these with the documented changes or the documented baseline values to look for changes. And those changes in vital signs can be just as important, if not more important, as the overall numbers, because that will show what is going on, right, with that. If we see, decreasing vital signs as far as becoming more problematic, more worrisome, farther away from normal, then we know that there's an underlying condition that is not being treated and can take them from the possible stable category to unstable. So we would refer them for further testing. And so that is the end of when we go about using vital signs for assessment. In the previous lesson, we obviously talked about how to assess these vital signs, but I wanted to specifically focus a little bit on when to use them. So as always, if you have any questions, please let me know. Otherwise, have a great day.